Ladies and gentlemen, welcome to the Screening and Identifying Alcohol Use in Primary Care conference call. Your host for today is Mr. Mark Lausch. You may now begin.
Thank you so much, Alfie. I appreciate that. My name is Mark Lausch, and I'm a licensed master social worker and a certified alcohol and addiction counselor for the state of Michigan. And we're going to talk today about screening and addressing alcohol use in primary care. For those of you that might have heard this presentation, maybe 8 or 9 months ago, I have updated some of the slides. So there's some new information here. So welcome. This is the August Lake Superior Quality Innovation Network Learning and Action Network webinar. You can ask questions in the chat box if you'd like. I do have somebody monitoring that. And I will send slides. The slides, will be available on the LSQIN website later this week. But if you email me at mlausch@mpro.org, I'd be more than glad to send you the slide deck. So let's start. So our objectives today, we're going to look at the reasons why screening for alcohol in primary care is important. Talk a little bit about some alcohol screening tools, the CAGE and the Audit C. Describe how to advise patients on hazardous drinking behaviors. And then a little bit about community resources and how to access them. And then at the end, just some common medications that are used to treat alcohol use disorders in primary care. So we're not going to talk today about diagnosing alcohol use disorders or anything like that. This is really just about screening and sort of identifying those that need brief advice or referral. So why is this important? Asking about alcohol use. So at-risk drinking and alcohol problems are common. About 1 in 3 adults in the U.S. engage in hazardous drinking. That is really drinking that elevates their risks for physical, mental, or social problems. Now, that does not mean they're alcohol dependent or they might not have alcohol disorders. They're just drinking at a rate and frequency that would be considered at risk or hazardous. Of these hazardous drinkers, about 1 in 4 will have an alcohol use disorder as defined by DSM-5. In recent studies of primary care practices, patients with alcohol dependence who receive the recommended quality of care, which would be, identification, assessment, and referral to treatment. Only about 10% of them, only about 10% of those problem drinkers actually required referral into specialty mental health or specialty substance abuse services. So the actual numbers of patients that you'll see that require referral to specialty substance abuse services is smaller. I'll show you Drinker's Pyramid at the end that kind of talks about that a little bit. So most patients don't have a problem with being screened for alcohol use, and most will be open to hearing advice. Even those patients with more advanced hazardous or problematic drinking do show some motivational readiness to change. Clinical trials have shown that brief interventions by primary care physicians definitely promote significant and lasting reductions in drinking levels for at-risk drinkers that have not progressed to an alcohol use disorder or alcohol dependence. And really only a small percentage of those you see and screen will require referral to specialty services, such as detox, inpatient, or outpatient services. Even those with severe alcohol use disorders will at times accept referrals to specialty services. And those that refuse initially might be accepting of those services in the future. So hazardous alcohol use. What are some of the things that alcohol use how alcohol use impacts diabetes? It slows the liver function. It does worsen nerve damage. It makes eye problems worse or impacts the nerves in the eyes, making vision worse. Reduces the effectiveness of diabetes medications and can negatively impair self-management. So drinking hinders the liver from releasing stored glucose, which can lead to dangerously low blood sugar levels. So it takes about 2 hours for the liver to break down the alcohol that is contained in one drink. So the energy spent in doing this would otherwise be utilized for healthy release of stored glucose. So all told, alcohol really does slow down the body's reaction time and disrupt the liver's ability to release glucose and may cause individuals with type 1 or 2 diabetes to slowly develop hypoglycemia. Alcohol abuse can also cause a condition known as hyperalgesia, in which the already damaged nerves become more sensitive to pain. So, in other words, if an individual with diabetes is already suffering from pain due to nerve damage, alcohol abuse can dramatically increase the amount of pain that is felt. So it makes drinking alcohol makes it much harder for the body to control the pain that may have developed due to diabetic nerve damage and may make the patient's condition dramatically worse. And obviously we know the jokes about alcohol causing blurred vision, and this because it impacts the alcohol as a sedative, it impacts the muscles of the body, and the eyes are controlled by a complex set of small muscles that get impacted when alcohol is present in the body. Cardiac patients. So the complications for patients who consume alcohol with a cardiac condition, alcohol can rise the levels of triglycerides in the blood, can lead to high blood pressure, heart failure, and increased caloric intake, and excessive and binge drinking does lead to stroke, cardiomyopathy, arrhythmias, and sudden death. But what about red wine? So some researchers have suggested that the benefit may be due to, So studies have been published in science journals about how drinking alcohol may be associated with reduced mortality due to heart disease. But what they found was that the benefit may be due to wine, like especially red wine. So others are examining potential benefits of components in red wine, such as flavonoids and antioxidants that do in fact reduce heart disease risk. So some of these components may be found in other foods such as grapes or red grape juice. So the idea of that wine would be the only thing that would contain flavonoids and antioxidants is, they can also be found in grapes and red grape juice. So the idea of a patient saying, well, I need to drink wine because it improves my cardiac function, they could easily be directed to another grape-based beverage. So the linkage reported in some of these studies that talk about the impact of red wine on cardiac conditions may be, the positive effects may be due to other lifestyle factors rather than alcohol. So such factors such as increased physical activity and a diet high in fruits and vegetables and lower saturated fat definitely does improve cardiac function. So no direct comparison trials have been done to determine the specific effect of wine or other alcohol on the risk of developing heart disease or stroke. Okay, I'm going to skip this one on the CS reported measure. And we're going to talk about now, moving into what is normal drinking. So what is considered normal drinking? Moderate alcohol consumption is seen as for men no more than 2 drinks a day, for women no more than 1 drink a day, and that would be then no more than 14 per week for men, 7 for women. And that would be a standard drink size. So that would be when someone is consuming a standard drink of a 5-ounce glass of wine, a 12-ounce beer, or about an ounce and a half or about a shot of distilled spirits. So this is taken from our alcohol pocket guide. Some of you who work with us in Michigan and maybe in Minnesota and Wisconsin too, we've developed an alcohol pocket guide that is a sort of a carry-along laminated guide to alcohol consumption and scoring for some of the alcohol screening tests. So this graphic is taken from the pocket guide. So no more than 2 drinks a day for men, no more than 1 drink a day for women. Now, the National Institute of I'm blanking on NIAA, but NIAA drinking guidelines, they talk about for 65 and younger, less than 4 drinks a day, no more than 14 a week. And binging would be 4 drinks, greater than 4 drinks or less within 2 hours. So the NIA drinking guidelines are kind of combined with what we took them from SAMHSA, the no more than 2 drinks a day for men, 1 for women. So somewhere in between there is the moderate drinking. So it would be, the recommendations that I always make is generally no more than 2 and less than 14 a week. But you could have a patient that might drink maybe 2 drinks a day, or 3 drinks a day for one day, maybe 1 drink a day the next, maybe 3 drinks a day the next, and still wouldn't necessarily be in the hazardous or risky. And we're going to get to that in just 1 second on the risky guidelines. Okay, so standard drinks are your 12-ounce glass of beer, and you can see there are other drink combinations of distilled spirits that have higher concentrations of alcohol, okay? So malt liquors, specialty beers, fortified wines, mixed drinks, things like that, can sometimes have higher alcohol concentrations than the 1.5 ounces of distilled spirits or the 5 ounces of wine or 12 ounces of beer. And here's some non-standard drink examples here. These will all be in the slide deck for those of you that want it, so I don't have to spend a lot of time on that. Okay, so what is hazardous or risky drinking? Okay, so when is, how much is too much? Okay, so we looked at what was considered normal drinking, which is really the recommendation I would make. It would follow SAMHSA's directions, which is really no more than 2 drinks a day for men, 1 for women, no more than 14 a week for men, and no more than 7 a week for women. So drinking becomes too much when it causes or elevates the risk for alcohol-related problems or complicates the management of other health issues, okay? So at-risk or hazardous drinking is really 4 or more drinks per day for men, or more than 14 a week for women, 3 or more per day, more than 3 or more per day, and more than 7 per week. Okay, so that's, you can see that the line between moderate and at risk is kind of blurry at times. So I mean, so sometimes again, screening tests are going to give you an idea of somebody that might be at risk for alcohol abuse or risky alcohol use. So there does become a time when the clinician will have to do some further questions or further assessment to really determine if there are any other psychosocial issues that are impacting the patient. So 4 or more drinks per day, or more than 14 per week, and more than 3 drinks a day for women, more than 7 per week is considered at risk or hazardous. Now, that doesn't mean that they have an alcohol use disorder. That doesn't mean they're alcohol dependent. It just means that their drinking is at a frequency, a rate and frequency that puts them in a category where they might be more susceptible or prone to developing problems. Okay, so these guidelines are not hard and fast rules that if somebody automatically drinks 4 or more drinks per day, they've got a problem. It just means that they're more likely to develop problems, or more likely that they may have developed problems already. So, and what are those problems? So we look at legal, financial, social, occupational, marital, medical issues. And when drinking complicates the management of other medical conditions, such as heart disease, diabetes, hepatic impairment, or liver problems, or kidney disease. So a patient's drinking becomes hazardous really when it causes problems. Father Joseph Martin is a recovering, he's passed away now, but he was a recovering alcoholic clergy who was instrumental in kind of bringing the discussion of alcoholism and the use of Alcoholics Anonymous into the public eye back in the 70s. And he always said, and I always remember this, and I've always used this in my clinical practice when I practice clinically, was that a problem is a problem if it causes problems. And I've always liked that. And what that means is that I interpret that is that if a person's drinking is causing problems, it is problematic. It doesn't necessarily matter whether they're drinking 4 drinks per day or 3 drinks per day or 12 per week or 14 per week or 22 per week or whatever. It's a problem if it causes problems. So remember, when we talk about screening, all we're doing is trying to identify those patients that may need further attention and some discussion. So, and also that a problem is a problem if it causes problems. It reminds us that each patient is individual and that the assessment or the recommendations that a physician will make to a patient about moderating or reducing their drinking will be individual to them. So what is heavy drinking? So according to SAMHSA, the heavy drinking is 5 or more drinks on the same occasion, okay, meaning same day, same evening, same 12-hour period, whatever, or on 5 or more days in the past 30. So this is somebody that is, would be drinking maybe heavily on the weekends. They might not drink at all during the week, but they might hit it hard on weekends when they're watching football on Friday, Saturday nights or Sunday afternoons, that type of drinker. So binge drinking, they're really similar, as you can see. 5 more drinks on the same occasion at least one time in the past 30. Or 4 or more drinks in less than 2 hours on any occasion. I mean, again, these are just general guidelines, and so the difference between binge and heavy is not significantly different. So, but you might get, I would say that somebody who doesn't drink Monday through Friday and drinks a lot on Fridays and Saturdays or Saturdays and Sundays, whatever, would be I would classify them a heavy binge drinker. I don't think the classification makes much difference, but they are definitely in the hazardous and risky area of drinking. So back to just looking, here's a slide on some of the effects of risky or hazardous drinking, not specifically related to cardiac or diabetes. All these things, I'm sure those of you who work in either clinical settings or in physician offices have seen these types of effects of hazardous drinking on their patients. I won't read them because they're self-explanatory. It's funny, in my clinical practice, I always tell patients that the likelihood of you dying from your addiction, alcohol or otherwise, or your alcohol abuse or substance abuse, is not going to be from the substance itself. It's going to be from a car accident, an accidental drowning, a fall down the stairs, hitting your head in the bathroom when you slip and fall after you've thrown up, a myriad of accidental or non-intended injuries or death caused by your being intoxicated. So it's not necessarily the substance that will do it. Although alcohol is toxic to every organ in the body. Definitely alcohol is chronic long-term drinking is definitely hazardous to all organs of your body. So we're going to move into this now. We talked a little bit about alcohol and its impacts on the physical body. We talked a little bit about showed you slides with some of the consequences of hazardous or risky alcohol use. We talked a little bit about some of the what would be considered moderate drinking, hazardous or at risk and heavy drinking. And now we go to the screening tools for alcohol use. So I'm going to show you 3 today. I'm going to go over briefly the first 2 and focus on the third. So the CAGE is a screening tool that's been used for many, many years. And its acronym stands for the 4 questions that are asked of the patient. It is a validated tool. It's easily memorized. It is a readily accepted screening tool. And so the questions you ask a patient: have you ever attempted to cut down on your drinking? Has anyone close to you ever been annoyed at your drinking? Have you ever felt guilty about your drinking? And have you ever drank in the morning or had an eye opener or drank after drink in the morning after drinking to feel better? This tool is not recommended by the Joint Commission, so I don't recommend this to be used in facilities that are accredited by Joint Commission because the CAGE tends to identify more problem drinkers and it misses those with less severe symptoms. Because if you really look at those of you that know about alcohol dependence or know some of the diagnostic criteria for alcohol use disorder or alcohol dependence, these are more advanced symptoms of drinking. than somebody who might be at the moderate sort of risky hazardous level. They're generally not going to think about cutting down. They probably not had anybody express the noise that they're drinking. They generally don't feel guilty, and they definitely don't have an eye opener. So the CAGE tends to identify more problem drinkers. And the CAGE scoring is here, so I will go through that. So the next tool is the 10-question audit, which is the alcohol use disorders inventory. What is the audit is the alcohol. I'm blanking on these acronyms this morning. But the audit is 10 questions, validated, reliable, used by many. The domains of the test include hazardous use, dependent symptoms, and harmful use. It is self-reported and clinician administered. Okay, so you can give it to a patient to take as well as administer or ask the questions yourself. The audit is generally, or the audit, excuse me, that's a typo there. The audit is more reliable than the CAGE and screening for early and risky hazardous drinking, and I'll tell you why. The domains of the audit include the first three questions look at hazardous alcohol use, frequency of drinking, typical quantity, and the frequency of heavy drinking, which would be the 5 or more drinks on one occasion, more than, I think, one time a month. The questions 4 through 6 talk about dependent symptoms. So impaired control over drinking or loss of control. Morning drinking, okay? And then the last questions talk about harmful alcohol use, which they talk about guilt, blackouts, alcohol-related injuries, and others concerned about drinking. So if you can see the questions on the CAGE kind of fall into the last kind of 4 questions on the audit. And so the CAGE identifies more problem drinkers. The audit is able to identify those that are more in the hazardous or risky area of their drinking. And the audit scoring is, I didn't include the audit scoring in here because most people don't use it because it's 10 questions. It's a lot longer to use, longer to administer, not by very much time, but it's still just a longer test to take, and patients tend to not want to take 10 questions inventory. So now we come to the Audit C, which is the preferred choice for screening for alcohol, and it is the modified version of the audit. It's validated and accepted by Medicare, Medicaid, and private payers. It can be used as a first-line screen, and then with any positive, it can then be the full audit can then be administered. There is a version called the U.S. audit, which is relatively new, and I think what's going to happen, I think eventually over time, the audit may be replaced by the U.S. audit, which is a variation on that, but I'm not going to go into that. The U.S. audit, the U.S. audit, which is a version of the Audit C. I think there's just a slight difference in how they ask the question. So this is a fully validated tool. It was developed and recommended by the World Health Organization. So what are the questions on the audit? They ask, how often do you have a drink containing alcohol? How many standard drinks containing alcohol do you have on a typical day? And how often do you have 6 or more drinks on one occasion? So patients that identify never, the other 2 questions are going to be irrelevant to them, and they would probably just skip those, or mark never here, or put none on here. As you can see, the first question will look at the frequency, monthly or less, 2 to 4 times a week, 2 to 3 times a week, and then how many standard drinks do you have on a typical day, give you an idea of whether they fall into the moderate drinking or the more risky and hazardous, and the last one talks a little bit, or kind of to identify a little bit about binge drinking or heavy drinking. So the scoring of the Audit C is really on a scale of 0 to 12, 0 meaning no alcohol use, because so each Audit C question has 5 answers, or 5 answer choices, and in men a score of 4 or more is considered positive, in women a score of 3 or more. Generally, the higher the score, the more likely a patient's drinking is affecting his or her safety. And so, again, you are screening. This is not a diagnostic test. It is a screening test. So if anybody, the higher the score, the more likely you might want to inquire a little bit more about some of the consequences of their drinking, talk to them a little bit about, if anyone express concern about your drinking, et cetera, et cetera. And we're going to get into that in just a second. But so generally 4 or more positive, 3 or more for 4 for men, 3 or more positive for women, and then generally the higher the score, the more likely the patient might be having some problems with their drinking. So moving now to, so once you screen somebody, what do you do with it? What do you do with them? So if you have a patient that scores, a man that scores 4 or more on the Odyssey, and a woman that scores 3 or more, you might want to talk to them about their drinking or provide some brief advice. And I recommend that we look at sort of framing the brief advice into a model developed by the CDC, and this is found in their publication, Planning and Implementing Screening and Brief Interventions for Risky Alcohol Use. And they talk about a flow model, which stands for feedback, F, listen for change talk, for the L, and O is options. And that's one framework for providing brief advice that I would highly recommend. And under the options menus, we'll talk about that in just a second. So the first, I'll talk a little bit more about these in detail, but the first, the flow, the F is providing feedback on the patient's alcohol consumption. So this can be, this is why standardized screening tool is important to use, because you have some information to give the patient and feedback to them about how they scored on the Odyssey or the audit or whatever you're using. Most of the practices that we're working with are, and I know this is an Epic and a lot of the other electronic health records of the Odyssey is the test that's being used. So you can tell them that the score that the score that they had puts them at a higher risk for alcohol problems. So you can use that screen as objective kind of evidence. And the second, you listen to change talk using reflection and summaries. You can assess the pros and cons of drinking, assess readiness to change, reflect and summarize, and then finally the menu, which means the options would be you follow a menu, which would be the choices being manage your drinking, eliminate your drinking, never drink and drive, no change, and then seek help, okay? So those are some of the options that physicians have in kind of working with patients. So let's talk a little bit more in detail about this flow model and some advice for how to provide, some suggestions for how to provide brief advice. So recommendation is that you introduce yourself. And if needed, introduce yourself as needed if they don't know you that well, and what you're trying to accomplish. So it's sometimes important to develop like an elevator speech about what you're trying to accomplish. So, for example, to provide the best quality health care, our practice discusses with all of our patients issues that affect your health, like smoking, exercise, diet, alcohol use, and mood states. So what you're doing is you're prefacing the screen that you're either going to give them or gave them, or that was given to them by the MA, that is all a part of a general approach to healthcare that looks at screening for hazardous or risky behaviors, okay? So it kind of normalizes the idea that you're not just asking them about their alcohol use, you're also asking them about other things in their lifestyle that might cause them problems. And ask permission to discuss the patient's alcohol use. So if we go back to the other slide about flow, feedback, you're going to ask them permission. Is it okay if we take a few minutes and talk about the alcohol screen you did in the waiting area, or the MA gave you, or whatever, or you and I did just a minute ago? If the patient says no, you're done. That's all you do. You just let it go, document that the screen was done, what the score was, that you, and whatever note that you may write, that you attempted to discuss the results of the screening with the patient and they declined at this time, that's okay. You don't push that. If they decline, that's one of the tenets of motivational interviewing is meeting with the patient, and these are all components of motivational interviewing. You meet the patient where they're at and let it go for that period of time. It's okay if they say no. So why might they decline to talk to you? Because all patients go through what's considered stages of change when you're talking, when they're contemplating or being presented with behavior change. Doesn't matter whether it's exercise, diet, smoking cessation, alcohol use, that patients oftentimes go through stages of change that include pre-contemplation, which is not even considering a behavior change. Contemplation. Then there's preparation, action, maintenance, and termination. So it depends on where the patient is at. Some of them may be open to talking about alcohol use. They may do it just to be polite, which is fine. Some may be vehemently opposed to talking about it, and that's okay. They're certainly at the pre-contemplative stage of change. But that's okay. So you put it down, and maybe next time they visit, you bring up the idea, the discussion of their alcohol use again. So if they agree to talk to you about it, you would typically ask, how much they're drinking. You'll have some of that information from the screening tool. How much they're drinking, how many times a week, what kind of alcohol is being consumed. Are they drinking standard drinks, or are they drinking, malt liquor, or some of the craft beers have higher alcohol content? Are they drinking mixed drinks? Are they mixing the drinks themselves? Half a bottle of vodka, a quarter ounce of orange juice. That type of thing, you get a little more information. Also, can ask them if they're using other medications that may synergistically affect alcohol use, such as over-the-counter sedatives, NyQuil, Somanex, if they're being prescribed benzodiazepines or opioids, if they're taking any over-the-counter medication that might impact alcohol. So the second part of the flow model. So you're going to listen for change talk. So providing feedback about screening results. One of the good strategies for talking to patients is ask them about what they don't like and what they like about the drinking. It's important to start with what they don't like, because that will give you some ideas on some ins that you can, or some conversation topics, or sort of a way to get into the conversation about their drinking. Because if they're going to talk to you about what they don't like, you can capitalize on it and say, well, I think you don't like the fact that your wife always is on your back about sitting in front of the TV drinking beer on every Sunday. Maybe we can look at modifying that a little bit. So you can find ways to get in with the patient and maybe identify some areas that might be where they might be amenable to change. Because I guess that most people don't like to be nagged about their drinking, or hearing that every weekend that they're drinking too much, or that they don't like the fact that they occasionally wake up hungover on Monday and they have trouble getting to work, or they don't like the amount of money they spend on drinking, or whatever it may be. Whatever the patient identifies the problem is, you can kind of jump in there and talk to them about some cons and pros of drinking. Okay? So ask the patient, once you determine, so they said that you can talk about their drinking. You talk a little bit more about it. You ask them maybe a little bit of questions, ask for some feedback, and listen for change talk. And then, again, you can ask them if they would like your medical advice. Again, this is another chance for them, for you to show that you're concerned about them. Use the motivational interviewing strategy by seeking permission to talk to them again, and ask if it's okay if you gave them some advice about drinking. And if they say yes, go ahead. If they say no, that's okay. And then you might get into some of the consequences of drinking. Hey, I understand you have cardiac issues, and alcohol might be negative to your cardiac condition, or you take these medications that might interact with alcohol, and here's the problem with that. So if there's anything specific as a physician or as a care manager that you know about the patient that you could insert into the conversation that would help them understand a little bit more about how alcohol may impact either their medical, social, legal, marital situation, typically would be medical in your physician setting. It's okay to kind of include that in there. You're not trying to scare them. You're not trying to say, hey, you continue drinking, you're going to die of a heart attack. Your cardiac condition is going to get so bad you'll fall over dead. Scaring people doesn't work. What you want to do is open a dialogue with them and start talking about that and helping them see that they're, and what they call in motivation is creating discrepancy. So you want them to see where they are now and kind of think about where they may be in the future. That's that creating discrepancy. It's the idea that, maybe they're right. Maybe that my drinking does impact my cardiac condition or my diabetes or my whatever. And it might be a good idea to do something about it. So you want to listen for that, the patient kind of dropping you hints that they're ready to either make change or to talk further. So again, listen for change talk. So you can summarize and reflect back when they make comments that are indicative of wanting to change. And then you can ask them if they're interested in changing their drinking habits. And that's when you can then jump into the menu, which is the manage, eliminate, never drink or drive, no change, seek help. So, and so the options for the patient, so you could say, so you and I have agreed to decrease the times you drink this week, during the week of Friday and Saturday only. Is this correct? So the options would be that the patient could learn how to manage their drinking, which means cut down, reduce, decrease the number of days, whatever you and the patient decide you want to do. They can choose to eliminate their drinking completely. You may get a patient that might say, hey, I think it's time for me to quit drinking. I've been thinking about it for a while. My wife says it's a good idea. I think it would help my job. It would help me lose some weight. I could, go back to the gym, whatever it may be. You may get patients that want to eliminate drinking from their lives. Encourage that too. You always want to recommend that they never drink and drive. That's definitely, if they don't agree to anything, suggest that they don't drink and drive, and for the obvious reasons. Now they may elect no change at all. All right. They may decide that they don't want to do anything about that. I'm perfectly fine the way I am. I don't think I drink too much, and thank you, goodbye. So in that situation, you could at least get them to commit to, at least verbally, to not drink and drive. And then those that might want to seek help, or that you might see as needing a referral for either detoxification or other types of treatment. And the statement that you could say, kind of roll it all together and say, like you and I have agreed to, you'll do this, and is that correct? And can we agree on that? So by providing options, you're allowing the patient to be in control and choose the option that best fits where they're at in stages of change, right? So you're not telling them to do anything other than suggesting they don't drink and drive. But anything else, it's going to be their choice. Okay, so they can tell you, nope, not going to drink any. I'm not doing anything. I'll see you later. I'll take it under advisement not to drink and drive. Thanks, or God heaven forbid, doctor, I never drink and drive. But it's not going to change anything, and that's fine. You're allowing them to exert some control, just like when you were asking them permission to talk to them. You were letting them be in charge and have some control in the relationship. Okay, and again, I'm spending 10 or 15 minutes telling you about these things. In reality, the conversation might take 2 to 3 to 5 minutes. That's it. I mean, it's not going to sometimes take a long time. If you have the luxury of a care manager or a social worker, they could do this kind of talk with the patient. And that's beautiful because they might have a little extra time. They might have an extra 5 or 10 minutes to spend with the patient to discuss with them some of these, to have the patient talk about their cons and pros of drinking, why they don't like it, why they do like it, to listen to change talk about possible options they could choose from. If you have that luxury, that's beautiful. If you're a physician working by yourself and don't have that, this kind of talk really only takes a couple of minutes. It really doesn't take a long time to do once you start doing it and kind of mastering it. So after you've agreed on a plan, seek agreement for a follow-up visit, 4 to 6 weeks, check on progress, and then thank the patient for their willingness to discuss their drinking. Thank them even if they tell you they don't want to talk about it. They thank you, and we'll, that's all for today. Thank them in any case, but especially thank the patients for being willing to discuss their drinking. Even those who don't want to make changes right now, remember you're planting a seed that might take some time to germinate. I don't mean to get corny there, but that is in fact very much the case. And don't get discouraged with patients who refuse to look at their drinking. Readiness to change is fluid. They might come back in another 6 weeks or 6 months or a month and say, maybe after they got their first DUI or after their wife has finally said, I've had enough, or I'm tired of your drinking and you're spending too much money, or they come to you and say, hey, guess what, I think you're right, I am spending most of my Sundays drinking and I don't like that. I don't think to spend that time with my kids, whatever. Patient change, readiness to change is fluid, and they could change. They might stay where they're at. There might be, you might get a refusal every time for the 4 more visits, whatever. You just keep, reminding them. Because ideally what's probably going to happen is you guys, hopefully what's going to happen is you'll be screening them at least once a year, if not more. Some practices do it every visit. Some do it once a year. As you update their medical history yearly, you can include the alcohol screen there and open up the discussion for them at that point again. Okay, so when is it time to recommend abstinence or advise abstinence? Okay, remember you're letting the patient choose their course. Either they're going to eliminate it, they're going to manage it, they're going to hopefully not drink and drive, they're not going to change it, they're going to seek help. But abstinence is recommended when the patient is pregnant or trying to conceive. They take any medications that contraindicate alcohol use or that have medical conditions that are exacerbated by alcohol use. Hepatic disease, cirrhosis, hepatitis A, B, or C, those types of things. If they're using a sedative, hypnotic, opioid, or other mood-altering substance, that would be some antidepressants, some mood stabilizers, some schizophrenic medications, urge caution or suggest abstinence, and if the patient makes the suggestion to stop completely. So if they ask to stop, then, again, back to that menu, that full process, eliminate drinking. They may want to eliminate drinking. Okay, so how long will intervention usually take? 5 to 15 minutes. For those of you that have the luxury of a care manager or social worker, the 15 minutes, they could spend some time talking with them. And then as little as 5 minutes, 3 to 5 minutes for a physician working on their own. So, how many patients will require intervention? Generally, there's some variation on the research on this. Some say as low as abstaining and low moderate drinkers are going to be approximately 90% of your population. There's others that talk about maybe 70%, so it's really 70 to 90%. The risky and hazardous non-alcohol dependent drinkers, approximately 10 to 15 to 20%, and then risky dependent drinkers, about 5 to 7%. And that depends on the researcher you talk to. So the Drinkers Pyramid, which is from the Institute of Medicine, and they look at the idea of the abstainers and low-risk drinkers being about 70%, unhealthy drinkers about 25%, and then alcohol-dependent drinkers about 7.5%. Okay, so it just depends. And each practice is going to be different. The population might be different. So it's really, the message is that abstainers and low-risk drinkers, okay, low-risk drinkers, which would fall into the low-risky category that might require either no intervention or just a suggestion maybe to cut down the frequency or the days they drink, are going to be about 75 to 90% of the patients you see. Okay, so then it's not a lot of patients that are going to be either unhealthy drinkers or alcohol dependent. Okay, so it's not a huge population. So the myth that screening for alcohol will open a Pandora's box of inundated with patients that require referral to outpatient or inpatient treatment or detox is just not borne out in reality. The numbers may differ, but the reality is that the majority of the patients that you see are going to be abstainers or low-risk drinkers, okay? They're easily dealt with. Okay, so coming into the home stretch here, we have treatment modalities available. We have, and this is the Maple Grove and Brighton local programs here, but there's detox, inpatient and outpatient detox. There's inpatient programs, intensive outpatient programs, which really meet typically 4 days a week for 3 or 4 hours. Outpatients, and there are 12-step programs, Alcoholics Anonymous, Narcotics Anonymous. If you're working with one of the Lake Superior Quality Innovation Network partners, which would be MPRO or Stratus, then you can talk to one of your quality consultants, and they can help you determine referrals for 12-step programs and treatment modalities in your area, okay, in your area. Remember, most patients aren't going to require this, but it's good to have referrals for outpatient services and detox, inpatients, IOP, that type of thing, near where you practice. Okay, so medications used to treat alcohol disorders. There's a couple of them. First is disulfiram or Antabuse, and that's the traditional old school medication. It is an aversive therapy. It interferes with the metabolism of alcohol. So what it does is it causes a buildup of a chemical called acetaldehyde, and acetaldehyde is toxic, so it causes extremely unpleasant side effects like flushed face, labored breathing, itchy skin, sweating, dysphoria, anxiety, that type of thing. It requires daily dosing. Many patients display tolerance either initially or over time to the negative effect. So patients drink on Antabuse, or they don't take their daily dosing. You have to be dosed daily. So either they don't take it or, so it's not good as a standalone intervention, and it really has fallen from favor. I'm sure there are some patients out there who might do well with that type of pharmacological intervention, but most it just doesn't work that as well as some of the others. Acamprosate or Camprol, that works by kind of moderating neurochemical balance in drinkers to promote abstinence and by reducing cravings. Camprol generally is well tolerated. The results are generally positive, whether that's a direct effect on the patient's neurochemical balance, reducing cravings, or a placebo effect by the idea that, if you suggest that they'll reduce cravings, it may in a patient. But in the time that in my clinical practice, I found that Camprol was, patients did generally report they liked it. It had very minimal side effects, if at all. And they did report that, at least anecdotally, that their cravings were reduced. So it's generally relatively safe for most patients. The final one is naltrexone. The trade names are Revia and Dpain. This works by blocking opioid receptors in the brain by competitive binding. Now, it was initially, naltrexone was initially used in opioid abstinence treatment because what it does, and what it still does, but still used today for that purpose, it blocks exogenously administered opioids. So if a patient is taking naltrexone and they've reached a steady state of the drug in their blood after maybe 5 days, if they take an opioid, it generally won't have any effect on them. The problem is they can't override that if they take more of the opioid and they could overdose. But generally, it does block the opioid effect. What they found in researching this is that in clinical trials, that a lot of patients that were in the clinical trials also used alcohol in addition to opioids, and they found that it reduced cravings for alcohol. And so they did some other clinical trials that they focused on reducing craving to drink, and it has been shown to decrease heavy drinking, number of days alcohol consumed, and the amount consumed. So it can be given for alcohol use, it can be given orally. For opioid abstinence, there is a depot injection called Vivitrol that is becoming more popular now with the opioid crisis, well, according to Donald Trump emergency now in the country. Vivitrol is used by those that can't or won't want to do other medication-assisted treatment like methadone or buprenorphine. So Vivitrol is given for that. But in treating alcohol disorders, it is used orally. It is relatively safe for most patients. It can cause some liver damage in some patients, especially in those with heavy drinking histories, longer drinking histories. It may also have some liver problems due to their drinking. So generally, liver function tests before and during treatment are recommended. So those are the three major medications used to now this is for treatment of patients with alcohol use disorder. But if you had a patient that was struggling with, staying abstinent because they were a risky or hazardous drinker and were struggling to stay abstinent, you might consider Camprol or Revia as an adjunct to their efforts to stay sober, maybe in conjunction with 12-step meetings or even maybe outpatient if they were doing that. So in conclusion, screening is important, relevant, and it does contribute to improved outcomes. The screening tools are really easy to administer and score. Really, even if you use the 10-question audit, the time to take that test for a patient is a couple of minutes. But most people are using the Audit C, which is simply, or the U.S. Audit, which are 3 questions, very easily administered, very easily scored, gives you some objective information to address, help address with the patient if you're moving into the area of brief advice. So brief advice definitely can improve your patient's drinking behaviors with minimal effort on your part. Just a simple, hey, you think you might want to cut down? That's perfectly legitimate and an example of brief advice. Medications can be used to support your patients, and there are referrals available typically within your own health system or in your community. So I would like to now open it up for questions if anybody has any.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key. If you do have a question at this time, please press the number 1 key. We're waiting for callers to join the queue.
Thank you very much.
Ladies and gentlemen, once again, if you have a question at this time, please press the number 1 key. If you have a question at this time, please press the number 1 key. Still waiting for callers to join the queue. We have no questions at this time.
Okay, then why don't we go ahead and we can put the evaluation questions up. If you could please just take a couple minutes to, actually probably 30 seconds to fill out the evaluation. I would greatly appreciate that because it helps us improve our presentations and maybe gives us some ideas for future webinars. So if the WebEx operator can put that up on the screen, we greatly appreciate that. If you have any questions, you can certainly email me at mloush, L-O-U-S-H, at mpro.org. I'll be more than glad to answer any questions for you. And I know I went through the material kind of quick, but I hope that you found some value in what we talked about today and picked up some tips maybe for working with patients on providing them some advice on how to cut down on their drinking. Could we have the evaluation questions up there, please? There we go. Thank you very much.